Welcome back to the Deep Dive. We're here again to really dig into the clinical evidence, the guidance, and pull out what you need to know.
Making sense of the science so you can use it.
Exactly.
Yeah.
And today, we are tackling something huge, something that affects so many people, often in silence. It's vaginal dryness. But it's more than just dryness, isn't it? We're looking at the bigger picture, what the experts now call Genitourinary Syndrome of Menopause, or GSM. And we're focusing specifically on the UK approach.
Yes, and that phrase, in silence, is so important. It's been massively undertreated. People are often told, oh, it's just part of getting older, put up with it.
Which is just not good enough.
Not at all, because this is a biological condition. It's complex, yes, but it's absolutely treatable. So our mission today is to lay out that clear, step-by-step guide based on the evidence.
Right. Starting with the basics, the non-hormonal stuff, then moving into the proven local therapies.
And also looking critically at some of the newer things you hear about, like lasers and injectables, putting them in their proper context.
Okay, let's start right there with the names. It gets confusing. We hear vaginal dryness, that's the symptom people feel.
Yep.
Then there's vaginal atrophy, which sounds a bit clinical, maybe scary.
It does. It describes the actual physical change.
And now the official term is GSM, Genitourinary Syndrome of Menopause. Why the change? What does GSM really cover?
It's a much better term because it captures the full scope. So vaginal dryness, that's the feeling, the lack of moisture. Simple enough.
Okay.
Vaginal atrophy is what a clinician sees. The tissue itself looks thinner, maybe paler, less elastic. The folds or rugae might be less pronounced. That's the biological change happening underneath.
Driven by low estrogen.
Exactly.
Yeah.
And GSM brings it all together. It's the modern umbrella term because low estrogen doesn't just hit the vagina and vulva.
Ah, right, the genitourinary part. It affects the urinary tract too.
Precisely. The lower urinary tract, the bladder base, the urethra shares the same embryonic origin as the vagina. It's packed with estrogen receptors too.
So when estrogen drops, those tissues suffer as well.
They do, which is why GSM covers not just the vulvovaginal symptoms, the dryness, the soreness, friction, pain with sex, or dyspareunia it's called, but also those connected urinary symptoms, things like urgency, feeling like you have to dash to the loo right now, frequency going more often, and really importantly, recurrent urinary tract infections, UTIs.
So treating the vaginal tissue can actually help the bladder symptoms?
Absolutely. It's an interconnected system. Using the term GSM helps everyone remember that. It's not just about sex. It's about urinary health and daily comfort, too.
Okay, that makes sense. So let's get into the why. What's the core biology here? Why does falling estrogen wreak this particular kind of havoc?
It's like a chain reaction, really, all stemming from those estrogen receptors in the tissues not getting their signal. When they're starved of estrogen, several things happen pretty quickly.
Like the thinning you mentioned.
Yes, that's the atrophy. The epithelial lining gets thinner, more fragile, it tears easily with friction, doesn't heal as well. Then there's reduced blood flow. Estrogen helps keep blood vessels healthy and responsive. Less estrogen means less blood flow, less elasticity, less natural plumpness to the tissue.
Which would affect arousal lubrication too, presumably.
Definitely. Slower response, less effective lubrication. But maybe the most critical change biologically is the pH.
Ah, right. I've heard about this. The vaginal pH is normally acidic.
Yes, very acidic. Healthy premenopausal range is usually around 3.5 to 4.5. That acidity is crucial. It's a natural defense mechanism.
And with low estrogen.
The pH starts to climb. It goes above 5, sometimes even 6 or higher, becoming more alkaline. And that shift is catastrophic for the vaginal microbiome.
Because the good bacteria can't survive.
Exactly. The protective bacteria, mainly lactobacilli, thrive in that acidic environment. They need a specific food source too, glycogen.
Glycogen, like a sugar.
Yeah, it's a sugar stored in the vaginal wall cells, but only when those cells are thick and healthy, which requires estrogen. So thin tissue means no glycogen storage.
No glycogen, no food for lactobacilli.
Right. The lactobacilli population crashes. And without them producing lactic acid, the pH stays high, the natural defense is gone, and the whole environment becomes fragile and much more susceptible to irritation and infections.
Wow. Okay, that's a really clear picture of the underlying biology. It's not just dryness, it's a whole system change.
It really is.
So that sets us up perfectly for this deep dive. We're going to follow that logic, how to diagnose it properly, how to manage it step by step, starting with foundational care and moving up.
Okay.
Right, let's get into section 1. Spotting the signs, telling it apart from other things, and knowing when to seek help urgently. Because GSM creeps up on people, doesn't it?
It really does. It's often gradual. People might notice a slight change and just think, oh, I'm just a bit tired, or maybe it's that new soap. They normalize it.
So what are those very first whispers, the subtle signs that things are changing and maybe need attention?
Often it's about baseline moisture and response. You might just feel generally less moist day to day. Nothing dramatic,
Yeah.
just different. Or the key early sign for many is during intimacy. Lubrication takes longer to happen, or when it does, it's just not quite enough. There's a little bit of friction, a slight draggy feeling that wasn't there before.
And outside of sex, what about just daily life?
That's where you might notice irritation from things that were previously fine, like that classic sandpaper feeling some people describe during a long walk or cycling, or even just wearing tighter trousers.
Friction from movement or clothes?
Exactly. Or inserting a tampon or a menstrual cup suddenly feels scratchy or uncomfortable. It used to be fine, now it's not. That's a clue that tissue quality has changed.
And you mentioned the urinary side. What are the early bladder or urine-related signs?
A really common one is stinging when urine passes over the vulva. Dysuria, it's called. The skin at the entrance is thinner and more fragile, so even normal urine can irritate it.
And you might mistake that for a UTI.
Easily. You think, oh, it stings when I pee, must be an infection. But the bladder itself might be perfectly fine. It's the external skin reacting. Also, that lingering feeling of rawness or soreness after you've been to the toilet. These are all signals that the tissue barrier isn't as robust as it used to be. Hashtag tag 1.2, distinguishing GSM from mimics and infections.
Okay, this is crucial. You feel burning or itching or soreness down there. It's easy to jump to conclusions. But you're saying not everything that burns is GSM. How do we start to tell the difference? This sounds like a diagnostic puzzle.
It can be, especially because things can overlap. GSM can make you more prone to infections, for instance. But there are clues in the pattern of symptoms, and especially discharge.
Right, discharge seems key. What are the typical GSM clues versus infection clues?
So with GSM, the symptoms are often linked to friction or pressure. The stinging is often right at the entrance, the vestibule, or that little fold at the back, the posterior fourchette. You might notice tiny splits or tears after sex that are slow to heal. And typically there's minimal discharge and, importantly, no significant change in odor. The feeling is often described as raw or sore.
Okay, minimal discharge, no bad smell, pain linked to friction. What about infections?
They usually have more distinct signatures. If it's thrush or candidiasis, the main symptom is usually intense itching, often deep internal itching, and it comes with that characteristic thick, white, maybe lumpy discharge, often described like cottage cheese.
Right, the classic thrush picture. And bacterial vaginosis or BV.
BV is different again. The main clue there is the odor, a distinct, unpleasant, fishy smell, often worse after sex, and the discharge is typically thin, watery, and grayish or sometimes greenish. Itching can be present, but the odor is the real hallmark.
So discharge and odor are really big differentiators.
They often are. But wait, there's more. We also have to consider skin conditions, dermatoses, and specific pain disorders.
Oh, right. Things that aren't infections or simple dryness.
Exactly. Like lichen sclerosis, LS. This is an inflammatory skin condition. It causes intense itching too. But visually, you see changes like bright white, almost porcelain-like patches on the skin. It can lead to scarring, fusing of tissues, and painful splits or fissures. LS needs specific treatment, usually potent steroid creams. It's not GSM.
Okay, very different look and treatment. What else?
Contact dermatitis. This is basically an allergic reaction or irritation from something touching the skin. Harsh soaps, fragrance pads or liners, laundry detergent, lubricants with irritants. It typically looks like a red, itchy, sometimes swollen rash.
So stop the offending product and it should clear up.
Usually, yes. And then there's vestibulodynia. This is trickier. It's nerve-related pain specifically located at the vaginal entrance, the vestibule. It can feel like a sharp, burning, or raw pain, even when the tissue looks completely normal and lubrication seems okay. It needs different treatments, often focused on calming down those hypersensitive nerves.
Wow, okay. Lots of potential mimics. But you mentioned GSM can actually lead to infections. How does that work?
Yes, this is such a critical point. Remember the pH change? When GSM makes the vagina less acidic, more alkaline.
Above pH 5.
Right. That alkaline environment is hostile to the good lactobacilli. Their numbers drop. This throws the whole ecosystem off balance.
Creating an opening for other things.
Exactly. It makes it much easier for opportunistic pathogens like Candida, the yeast that causes thrush, or the anaerobic bacteria associated with BV to overgrow. They love that less acidic environment.
So you could have the underlying GSM, dryness, and soreness, plus an actual infection on top.
Absolutely. It's a very common scenario. And this is why, if you think you have recurrent thrush that just keeps coming back despite using antifungal creams, you have to consider if underlying GSM is the real driver.
Because the antifungal treats the yeast but doesn't fix the fragile tissue or the high pH.
Precisely. You're treating the symptom, not the root cause. The environment stays vulnerable, so the infection just comes back. Addressing the GSM tissue health and pH is often the key to breaking that cycle.
Okay, with all these possibilities, dryness, infection, skin conditions, nerve pain, it feels like getting the right diagnosis is paramount. But exams can be daunting. When is a physical examination absolutely necessary versus when can a diagnosis be made just based on symptoms?
That's a fair question. The good news is, for many people with straightforward, typical symptoms of dryness, maybe a bit of soreness with sex, maybe some urinary urgency starting, GSM can often be diagnosed clinically.
Meaning just based on the story the patient tells.
Yes, based on a thorough history of your symptoms. If the picture sounds very typical for GSM and there are no red flags or confusing features, it's often reasonable to start with the foundational non-hormonal treatments we'll discuss based on that history alone.
But when does the doctor or nurse really need to take a look?
An examination becomes much more important if the symptoms are severe, if they're not responding to initial simple treatments, if the picture is unclear, or if there's any suspicion of those mimics we talked about, like possible thrush, BV, or a skin condition like lichen sclerosis.
And what's the goal of the exam?
It's really threefold. First, to confirm the signs of GSM, to actually see that the tissue looks thin, maybe a bit pale, perhaps lacks those normal folds. Second, to exclude other things, is there obvious discharge suggesting infection? Are there white patches or skin changes suggesting LS? Third, to localize the pain, where exactly does it hurt? Is it generalized soreness or is it very focused pain right at the entrance, which might point towards vestibulodynia?
Makes sense. What about tests? You mentioned pH. Are swabs or other tests routine?
Tests are definitely selective, not automatic. A vaginal pH test is simple and quite useful. If the pH is above 5, it strongly supports a diagnosis of GSM.
Okay.
Swabs for culture or microscopy are only really needed if there's significant discharge or odor that makes you suspect BV or thrush, or perhaps if there's persistent redness that isn't explained. We don't swab everyone routinely.
And urine tests?
Only if urinary symptoms like burning, frequency, or urgency are dominant to confirm or rule out an active UTI. Again, testing to answer a specific clinical question.
What about biopsies? That sounds quite invasive. When would that ever be needed?
Biopsies are really reserved for specific situations. They're not part of a routine GSM workup at all.
Okay, sure.
You'd only consider a biopsy if there are atypical features like persistent, non-healing sores or ulcers, rapidly changing white patches, or unusual lumps or bumps that don't fit a clear diagnosis or aren't responding to standard treatment.
So mainly to rule out something more serious, like LS or, very rarely, precancerous changes.
Exactly. It's for getting clarity on unusual skin changes, not for diagnosing typical GSM dryness or soreness. Hashtag 1.4. Critical red flags. When to seek urgent review.
Right. Before we even think about treatment, we need to cover safety. What are the absolute stop everything and get checked out now signs? The critical red flags that mean self-care is off the table and you need urgent medical assessment.
This is non-negotiable. These symptoms always need prompt evaluation. Top of the list. 1. Any new postmenopausal bleeding. That means any bleeding, spotting, anything at all that happens 12 months or more after your last period. Even if it's tiny, even if it only happens once, it always needs investigating urgently.
Okay. Number 1, postmenopausal bleeding. What else?
2. Fever or feeling generally unwell, chills, shakes alongside pelvic symptoms. This could mean a more serious infection spreading beyond the local area. 3. Severe, sudden pelvic or lower abdominal pain. Could be something unrelated but serious, needing immediate attention. 4. A really foul-smelling discharge, especially if you feel unwell. While BV has an odor, a truly foul smell, maybe greenish with systemic symptoms, needs urgent check for infection. 5. Seeing visible blood in your urine, not just stinging, but actually seeing blood, needs investigation of the urinary tract. 6. Noticing any new lumps, bumps, sores that don't heal, or rapidly changing white patches on the vulva. These need looking at quickly to rule out skin condition and other serious issues.
That's a clear list. So if someone experiences one of these, say, a bit of unexpected spotting, what's the immediate action? Stop any treatments they've started?
Absolutely. Pause everything, any new creams, moisturizers, definitely any procedures like laser if they were considering it. The priority immediately shifts to getting that red flag symptom diagnosed.
Don't try to treat the dryness while waiting for the appointment.
No. Get the urgent appointment booked and explain the red flag symptom clearly. Investigating potential serious causes has to come first. Comfort can wait until safety is confirmed.
Okay, assuming no red flags, we're moving into treatment. And the UK guidance is really clear. Start with the foundations, the non-hormonal steps.
Yeah.
This is where, as you said, simple daily choices can make a huge difference, right? Often people are doing things that sabotage their own comfort without realizing.
Absolutely. Think of GSM tissue as being like sensitive skin, say like eczema, but internally and externally down below. It's lost its protective barrier. So the first thing you must do is remove anything that could be irritating it further.
Creating a calm baseline.
Exactly. You're trying to stop that cycle of irritation. If you don't, any treatments you add later will be fighting an uphill battle.
Right.
Hashtag 2.1, everyday habits to reduce irritation.
So what are the key habits to change? Let's start with washing, hygiene.
Keep it incredibly simple. The golden rule for the external vulva is lukewarm water only. Just rinse gently. That's usually enough to cleanse away sweat and normal secretions.
No soap at all. Not even gentle or intimate washes.
Ideally, no soap. Most soaps, even mild ones, are alkaline and strip the natural oils from already fragile skin. Those special intimate washes are often no better. Many contain perfumes or unnecessary chemicals.
What if you feel you really need something more than water?
If you must use a product, the best option is a bland emollient cream or ointment, the kind used for eczema used as a soap substitute. Apply a small amount, gently cleanse externally, and rinse thoroughly.
And definitely avoid.
Avoid all fragranced products down there. Bubble baths, scented pads or liners, vaginal deodorants or perfumes, harsh detergents for underwear. They are all potential irritants. Aim for neutral.
Makes sense. What about friction? We talked about sandpaper feeling. How do you minimize mechanical irritation day to day?
It's about fabric and fit. Wear breathable underwear, preferably 100% cotton, especially at the gusset. Avoid synthetic fabrics that trap heat and moisture right against the skin.
And tight clothing.
Yes, loose-fitting clothing is generally better. If you do wear tight things like gym leggings or cycling shorts, make sure to change out of them immediately after exercise. Don't sit around in damp, tight gear. That combination of trapped moisture, heat, and friction is really tough on sensitive skin.
You also mentioned friction at the entrance, the posterior fourchette. Anything specific for that?
That area is particularly vulnerable. Being gentle during any kind of insertion, tampons, fingers, applicators is key. Using lubricant even for non-sexual things like inserting a pessary can help if it feels scratchy.
Okay. And lifestyle factors. You mentioned smoking and hydration earlier. How do they fit into this foundational care?
They're important background factors. Smoking is definitely linked to worse GSM symptoms. It impairs blood flow, which the tissues desperately need, and it seems to reduce the body's own estrogen activity. Quitting smoking can genuinely help tissue health.
And hydration. Does drinking more water directly help vaginal moisture?
Not directly in the sense of curing the atrophy, but good overall hydration supports all body tissues, including healing. Also, things that dehydrate you, like too much alcohol or caffeine, can sometimes make symptoms feel worse, perhaps indirectly by affecting sleep or general well-being. It's about supporting the whole system. Hashtag 2.2. The role of vaginal moisturizers.
Right, we've calmed things down by removing irritants. Now, the next non-hormonal step is actively adding moisture back in. Let's talk about vaginal moisturizers. You drew that analogy like face cream for the vagina.
That's a great way to think about it. Vaginal moisturizers are designed for regular, scheduled use. They work over time to improve the baseline hydration and condition of the tissue itself.
How do they work? What's in them typically?
Many contain ingredients like hyaluronic acid, HA, which is a powerful humectant. It draws water into the tissue and holds it there. Others might contain vitamin E or other soothing ingredients. The goal is to help the tissue retain moisture between applications, making it feel more comfortable and resilient day to day.
So it's not just for immediate relief during activity.
No, that's the key distinction. Moisturizers are for maintenance, for improving the general state of the tissue over days and weeks. Lubricants are for immediate friction reduction during specific activities.
Okay. So how should someone use a moisturizer? What's the routine?
The idea is to start consistently, maybe 2 to 4 times per week, often applying it at bedtime, using the applicator provided, or just a clean finger is easiest.
Every night.
Not necessarily. You start regularly, maybe every other night or every third night, and then you adjust. The goal is to find the lowest frequency that keeps you comfortable day to day. Some people might find twice a week is enough once things improve.
And how quickly should you notice a difference?
You should start feeling some improvement in general comfort, maybe less of that dry, papery feeling within days to maybe a couple of weeks. It's relatively quick for improving baseline comfort.
But it won't necessarily be enough on its own for comfortable sex.
Probably not for many people. It improves the tissue quality, which helps, but you'll likely still need that extra slipperiness from a lubricant right when you need it. Moisturizer is the background conditioning. Lubricant is the performance enhancer for reducing friction. Hashtag tag tag 2.3. Choosing the right personal lubricant for friction control.
Okay, that leads us perfectly to lubricants, the essential tool for managing friction during an activity sex, using dilators, even during a pelvic exam perhaps. What's the most common mistake people make with lube?
Two big ones. Not using enough and not putting it in the right place.
Right place. You mean not just internally?
Exactly. So much of the pain and friction in GSM happens right at the entrance, the vestibule and that posterior fourchette area we mentioned. If you only put lube high up inside, you miss the main friction spot.
So where should it go?
Be generous. Apply it externally all around the entrance, paying particular attention to that back rim, the fourchette, and apply it before any contact or insertion begins. You also need some internally, of course. And crucially, reapply if things start to feel draggy or dry during the activity. Don't try to push through friction.
Okay, be generous, apply to the entrance, and reapply. Now, the types. Water-based, silicone-based, oil-based. What are the pros and cons, especially for sensitive GSM tissue?
Let's break them down. Water-based. These are the most common. Pros.
Yeah.
Very versatile, easy to clean up, and generally safe with condoms and most sex toys. Cons. They can sometimes dry out a bit quickly, needing reapplication. And we'll come back to this. Some formulas can be irritating due to ingredients like glycerin or high osmolality.
So good.
Silicone-based. Pros. These offer the longest lasting glide. They are incredibly slippery and don't dry out. Excellent for significant dryness or entrance pain. Also generally condom safe. Cons, they can feel very slick, which some people don't like. And you need to check compatibility with silicone toys, as silicone lube can sometimes degrade silicone toys over time. Cleanup might need soap and water.
And oil-based, like coconut oil or specific oil lubes.
Oil-based. Pros. Can feel very rich and natural, long-lasting glide, too. Cons, the big one. Oil degrades latex. So oil-based lubes are generally not safe with latex condoms or latex diaphragms. They can cause them to break. They can also stain fabrics and be harder to wash off the skin.
That latex warning is critical. Okay, now you mentioned irritating ingredients and osmolality with water-based lubes. What's that about? What about all those fun lubes, warming, tingling, flavored?
Right, this is super important for sensitive tissue. Avoid the fun formulas. Warming, tingling, or flavored lubes almost always contain irritants like menthol, capsaicin, perfumes, or sweeteners. These can really sting and burn fragile GSM tissue.
And osmolality, that sounds technical.
It is a bit, but it's key. Osmolality basically measures the concentration of particles dissolved in the lubricant. Healthy vaginal tissue has a certain natural osmolality.
Okay.
If a lubricant has a very high osmolality, often because it contains lots of glycerin, sugars, or certain glycols, it acts like a sponge. It literally pulls water out of the vaginal cells by osmosis.
Dehydrating the already dry tissue.
Exactly. This causes immediate stinging and burning. People often think they're allergic, but it's usually an irritant reaction caused by this osmotic effect. It's damaging the cells. Ideally, yes. Look for lubricants marketed as being isoosmolar or having an osmolality in the physiological range, around 270, 370 millilangams Q-estri. And always choose fragrance-free. Simple is best. If a lubricant stings or burns, stop using it immediately. It's not helping, it's harming.
Okay, we've built the foundation. Remove irritants, add baseline moisture with a scheduled moisturizer. Use a good, non-irritating lubricant for friction. But what if that's still not enough? If dryness, pain, or those urinary symptoms are still impacting life?
Then we move to the next layer in the UK guidelines, which is addressing the underlying biology. And the workhorse here is local vaginal estrogen, or LVO.
Right, so this is different from just managing symptoms. It's actually trying to reverse the tissue changes.
Precisely. This is where it gets fascinating, because LVO directly targets that root caused the lack of estrogen in the tissues themselves. It's not just papering over the cracks. It's helping rebuild the wall.
So how does putting a tiny bit of estrogen directly into the vagina work to fix the problems we talked about? The thinning, the pH shift, the loss of good bacteria?
It works by replenishing those starved estrogen receptors right there in the vaginal vulva lining and also in the urethra and bladder base. It's like giving fertilizer to depleted soil.
And what does that fertilizer do?
It triggers a cascade of positive changes. 1, tissue thickening. The lining starts to mature and thicken again, becoming more resilient, less fragile. That's the reversal of atrophy. 2, glycogen returns. As the tissue thickens, it starts storing glycogen again. Remember, that's the food source for lactobacilli. 3, lactobacilli flourish in pH drops. With food available, the lactobacilli can repopulate. They produce lactic acid, and the vaginal pH drops back down towards that healthy acidic range. The natural defense system is restored. 4, blood flow and elasticity improve. Estrogen also helps improve local blood flow, which brings nutrients, helps with healing micro tears, and improves the tissue's natural elasticity and lubrication response.
Okay, that sounds like it addresses all of the core biological issues. But people hear estrogen and immediately think HRT, hormone replacement therapy. They worry about risks, side effects like weight gain, blood clots, cancer risks. How is LVO different from systemic HRT?
That's a really common and understandable concern, but it's based on a misunderstanding of the dose and absorption. LVO uses a tiny, tiny dose of estrogen compared to systemic HRT, like patches, gels, or pills used for hot flashes.
Oh, tiny.
Very tiny. And it's applied locally. The vaginal and vulval tissues are packed with estrogen receptors, so they basically soak up that small dose very efficiently right where it's needed.
So it doesn't really get into the rest of the bloodstream much.
Exactly. Systemic absorption is extremely low. Once those local receptors are saturated, very little gets absorbed into the general circulation to affect other organs like the breasts or the uterus, or to cause systemic side effects. Blood estrogen levels usually stay well within the normal postmenopausal range.
Whereas systemic HRT is designed to raise blood levels to affect the whole body.
Correct. Systemic HRT aims to relieve symptoms like hot flashes and protect bones systemically. LVO is purely about local tissue health in the genitourinary area.
So the safety profile is very different.
Very different. LVO is considered safe for the vast majority of people, including many who might not be candidates for systemic HRT.
What about people with a history of hormone-sensitive cancers like breast cancer? That's often a major concern.
That's obviously a situation needing careful, individualized discussion with their oncology team. However, because the systemic absorption is so minimal, many specialists now consider LVO safe and potentially very beneficial for quality of life, even in women with a history of breast cancer, particularly if they're on treatments like aromatase inhibitors, which can worsen GSM. The potential benefits for comfort and bladder health often outweigh the theoretical, very low risk from minimal absorption. But it must be a discussion with their specialist.
Okay, and can you use LVO alongside the non-hormonal things, moisturizers, lubricants?
Absolutely, and you should. They work beautifully together. LVO fixes the underlying biology over weeks and months. Moisturizers provide daily comfort and hydration. Lubricants manage friction during activity. It's a layered approach. Hashtag tag 3.2. Formulations and targeted placement.
Right, so if someone decides LVO is the next step, there seem to be different ways to get it in there. Creams, little tablets, or pessaries, even a ring. Do they all work the same?
The evidence suggests that all the licensed forms, creams, pessaries, tablets, which usually contain estradiol, and the estradiol releasing ring provide comparable relief from GSM symptoms over time.
So how do you choose which one?
It really comes down to personal preference, maybe dexterity issues, and importantly, where your symptoms are worst.
Ah, okay. So the main problem is that stinging or soreness right at the entrance.
Then a cream formulation is often preferred. Because you apply it with a finger or an applicator, you can make sure to spread a small amount directly onto the external vulval area and the entrance, that posterior fourchette, as well as delivering it internally. You get targeted treatment right where the friction hits hardest.
Makes sense. What about the tablets or pessaries?
Tablets or pessaries are often liked because they're very clean and quick to insert. Minimal fuss, minimal residue. They're great if the main symptoms are internal dryness or those urinary symptoms, as they deliver the estrogen primarily inside the vagina.
And the ring. That sounds convenient.
The ring is sort of the set and forget option. It's a soft, flexible ring that sits inside the vagina and slowly releases a very steady, ultra-low dose of estradiol over about 3 months.
So you just put it in and leave it?
Pretty much. It's great for people who might forget doses or have difficulty with regular application. The main thing to know is that it primarily treats the internal tissues. So if someone still has significant external soreness at the entrance while using the ring, they might need to occasionally add a tiny bit of estrogen cream externally or use a good non-hormonal moisturizer there.
So again, it might be about combining things for best effect.
Very often, yes. Finding the right combination that addresses your specific pattern of symptoms. Hashtag tag tag 3.3. Timelines for hormonal relief.
We know LVO is working on the biology, thickening the tissue, changing the pH. That sounds like it won't be an overnight fix. What's the typical dosing schedule, and how long does it take to feel results?
You're right, patience is key. It's a biological process. Most LVO treatments start with a loading phase.
What does that mean?
It usually means using the product more frequently at the beginning, often once daily, or maybe every other day for the first 2 to 3 weeks. The idea is to quickly saturate those estrogen receptors in the tissue to kickstart the healing process.
Okay, saturate the tissue first. Then what?
Then you drop down to a maintenance dose. This is usually much less frequent, typically just twice a week. That lower dose is enough to keep the tissue healthy and prevent the symptoms from returning now that the initial repair has happened.
And the timeline for feeling better. When should you notice changes?
You might notice some early relief, maybe less stinging with urine, or the tissue feeling a bit less papery within 2 to 4 weeks of starting.
But the full effect takes longer.
Yes, the fuller benefits, like improved elasticity, better natural lubrication response, significant reduction in pain with sex. That often takes longer to develop as the tissue structurally remodels. You're typically looking at 8 to 12 weeks to see the maximum improvement.
So you need to stick with it for a few months to really judge if it's working fully.
Absolutely. Don't give up after just a couple of weeks if things aren't perfect yet.
And is it a cure? Can you stop using it once the tissue is better?
That's a really important point. LVO is a treatment, not a cure. GSM is caused by the ongoing low estrogen state of menopause. If you start the LVO, the estrogen levels in the tissue will drop again, and the symptoms will gradually return over weeks or months.
So it's usually a long-term maintenance thing, using it maybe twice a week indefinitely.
For most people, yes. It becomes part of their long-term routine to maintain tissue health and comfort, just like managing any other chronic condition. Hashtag tag 3.4. Alternatives to estrogen.
Now, what about people who absolutely cannot use estrogen? Even the tiny local dose, or strongly prefer not to for personal reasons? Is there anything else that works on the biology?
Yes, there is a guideline-supported alternative. It's called vaginal DHEA. The generic name is Presterone. It comes as a vaginal pessary.
DHEA. Isn't that another hormone?
It is, but it's a precursor hormone. It's not active estrogen itself when you insert it.
So how does it work then?
The clever thing about DHEA is that the cells within the vaginal wall contain the enzymes needed to convert that DHEA into active hormones, both estrogens and androgens, like testosterone metabolites right there, locally within the tissue.
Ah, so the body does the conversion itself where it's needed.
Exactly. It uses the DHEA as building block to make what it needs locally. Research shows it's effective at improving the tissue quality, reducing dryness, and easing pain with sex in women with GSM.
So it's a good option for someone seeking a biological treatment but wanting to avoid putting actual estrogen into their body.
Yes, it's a recognized effective alternative pathway. Like LVO, it addresses the underlying tissue changes.
And would you use it with moisturizers too?
Yes, definitely. It's often recommended to use vaginal DHEA on its scheduled nights, usually nightly, and perhaps use a non-hormonal moisturizer on the off nights, or as needed for day-to-day comfort, especially while the DHEA is starting to work. Again, layering the approaches.
Right, we've covered the absolute cornerstones recommended by UK guidelines. Foundations first, irritant avoidance, moisturizers, lubricants. Then, if needed, local hormonal therapy, LVO or DHEA. Now we need to talk about the other things people hear a lot about, the adjuncts. Things like lasers, radiofrequency, injectables. These get a lot of media hype.
They do, and often they're presented as miracle cures or first-line fixes, which is really misleading. It's crucial we put these into their proper context based on the evidence and guidance.
Setting realistic expectations is key here.
Absolutely, and understanding where they fit in the treatment pathway, which is generally after the basics and local hormones have been tried and optimized, or if hormones genuinely aren't an option. Hashtag tag 4.1. The role of energy-based devices, laser RF.
Let's start with energy devices, things like vaginal laser, CO2 or erbium.YAG, and radiofrequency, RF. What does the official UK guidance actually say about using these for GSM?
This is really important for listeners in the UK to know. NICE, the National Institute for Health and Care Excellence, which provides NHS guidance, classifies vaginal laser therapy for GSM symptoms as investigational.
Investigational, what does that mean in practice?
It means NICE considers that there isn't enough high-quality evidence yet to be sure about its long-term effectiveness, how it compares to established treatments like LVO, and its long-term safety. Therefore, they recommend it should currently only be offered within the context of research studies.
So if a private clinic is offering it as a standard treatment outside of a trial,
They are operating outside of that standard NHS guidance framework. It's also worth noting the FDA in the United States has issued warnings about these devices being marketed for vaginal rejuvenation, citing potential harms like burns, scarring, and pain, alongside unproven benefits for GSM specifically.
okay, so the official stance is cautious due to lack of strong evidence. Where do they fit in then, if at all?
They are positioned firmly as adjuncts, meaning they are not first line. They should only really be considered if someone has optimized the foundational care and tried local hormone therapy, LVO or DHEA, and is still having significant problems, or if hormonal therapy is absolutely contraindicated or declined.
They're further down the line.
Much further down the line. They are not a replacement for addressing the underlying low estrogen, if possible.
How are they supposed to work? What's the theory?
The idea is that these devices deliver controlled heat energy, either light from a laser or radio frequency waves, into the vaginal wall tissue. This controlled microinjury is intended to stimulate the body's natural healing response.
Triggering collagen production.
Yes, encouraging new collagen formation, potentially improving blood flow, and maybe thickening the tissue slightly. That's the theory.
And if someone does go down this route, what's the treatment schedule and timeline like?
It typically involves an initial series of treatments, usually 2 or 3 sessions, spaced about 4 to 8 weeks apart. Any improvements tend to be gradual, building up over the weeks following the sessions.
Is it a permanent fix, considering the cost and effort?
No, the results are generally not permanent. Because the underlying cause, the low estrogen state, hasn't changed, the tissue will likely revert over time.
So maintenance might be needed.
Yes, clinics often suggest maintenance reviews or top-up sessions, perhaps every 6 to 12 months, to maintain any benefits. The effects seem to last longest when people are also diligent about using non-hormonal moisturizers, and ideally local hormones if they can, alongside it. Hashtag TAG 4.2, regenerative injectables, PRP, and polynucleotides.
Okay, similar buzz around injectables. We hear about PRP, platelet-rich plasma, and newer things like polynucleotides, PN, being pitched as ways to regenerate the tissue. What's the evidence status for these in treating GSM dryness?
Again, the key word is emerging. The evidence for both PRP and polynucleotides, specifically for vaginal dryness and GSM symptoms, is still quite limited. There are some promising early studies, but we don't have large, robust trials confirming long-term effectiveness or comparing them directly against standard treatments like LVO.
So, like the lasers, they're considered adjuncts.
Definitely. They fall into the same category. Things to consider only after optimizing foundations and local hormones, or if hormones aren't an option and significant symptoms persist. They're not a starting point.
What's the thinking behind how they might help?
They're both aiming to improve the quality and health of the surface tissue. PRP uses the patient's own concentrated platelets and growth factors taken from a blood sample. The idea is these growth factors might stimulate healing, improve blood supply, and potentially reduce inflammation when injected into the target areas, like the vaginal entrance.
And polynucleotides, what are they?
Polynucleotides, PN, are basically purified fragments of DNA, often derived from salmon sperm, actually.
Salmon sperm, really?
Yes, sounds unusual, but it's highly purified. These DNA fragments act as biostimulators. They don't provide volume like a ciller, but they're thought to signal to the local cells to improve their own matrix production, hydration, and healing capacity. They kind of encourage the tissue to repair itself.
How are these administered? Is it similar to the laser schedule?
Yes, the treatment schedule is often similar, typically an initial series of 2 or 3 injection sessions, spaced 4 to 8 weeks apart.
Are there specific safety things to be aware of with injectables?
Yes. With PRP, because it involves drawing and re-injecting your own blood components, the main considerations are around managing bleeding or bruising risk, especially if you're on blood thinners, anticoagulants. With polynucleotides, if they are salmon-derived, the absolute key exclusion is a severe fish or shellfish allergy. That would rule out using those particular products. Any injectable procedure carries small risks of bruising, swelling, or infection at the injection site.
So again, interesting science, but still supplementary, not foundational.
Precisely. Tools that might help in specific situations for some people, but not the first thing to reach for, and the long-term data is still evolving. Hashtag tag 4.3. Managing pain beyond dryness. Holistic care.
This is so important. We focused a lot on the tissue, dryness, and fragility. But pain during sex dyspareunia isn't always just about lack of lubrication, is it? It gets more complicated, especially if pain has been going on for a while.
Absolutely. This is where holistic care is vital. Once you've experienced pain with sex repeatedly, your body and brain start to react defensively. A key reaction is pelvic floor muscle overactivity, or guarding. The muscles around the vagina and deep in the pelvis unconsciously tighten up in anticipation of pain or as a response to it.
Like bracing yourself.
Exactly. But it becomes a chronic subconscious pattern. These muscles get tight, tense, and can develop trigger points. And that muscle tension itself becomes a major source of pain, often a sharp, burning, or deep aching pain that persists even if the surface tissue is well lubricated or treated with hormones.
So adding more lube or even LVO won't fix that muscle-driven pain.
No, because the problem is now in the muscle function, not just the skin surface. This is where pelvic health physiotherapy is absolutely essential.
And what does a pelvic physio do? Is it just Kegels?
Usually the opposite. If the muscles are overactive and tight, the last thing you want to do is more tightening exercises like Kegels. Pelvic physio for pain often focuses on down training.
Down training. Learning to relax them.
Yes. Using techniques like diaphragmatic breathing coordinated with pelvic floor relaxation, sometimes called a reverse Kegel, manual therapy to release trigger points, stretches, and often using graded vaginal dilators.
Dilators. To stretch the muscles.
Not just stretch, but to help retrain the brain-muscle connection. They help desensitize the area and teach the muscles to allow comfortable insertion without that automatic guarding response. It's about restoring normal muscle function and reducing fear.
And lasers or injectables can't do that.
No. Devices and injectables work on tissue quality. They cannot relax overactive muscles. That requires specific neuromuscular retraining, which is the domain of pelvic physiotherapy.
Beyond the muscles, there's the psychological impact too, right?
Yeah.
Fear, anxiety.
Huge impact. Painful sex inevitably leads to anticipatory anxiety. You start dreading intimacy because you expect it to hurt. This fear itself triggers muscle guarding and can shut down natural arousal and lubrication, creating a vicious cycle.
The fear avoidance cycle.
Exactly. This is where psychosexual therapy or counseling can be incredibly helpful. It addresses the fear, the anxiety, helps rebuild confidence, improves communication between partners, and supports gradually reintroducing intimacy in a positive, non-pressured way alongside the physical treatments.
And one more point. What if the pain isn't just superficial, but deep inside?
That's a red flag for looking beyond GSM. If the dominant pain is deep pelvic pain during intercourse or chronic pelvic pain outside of sex, we need to think about other possible underlying conditions, things like endometriosis, adenomyosis, interstitial cystitis bladder pain syndrome, or even musculoskeletal issues originating from the back or hips.
So don't just keep escalating surface treatments if the main problem feels deep.
Correct. A thorough assessment is needed to identify the primary pain driver. Treating GSM is important, but it won't fix deep pain from endometriosis, for example. Hashtag tag 4.4. Safety and treatment sequencing.
We've talked about layering treatments. This sounds like it needs careful management. What are the safety rules for introducing things, especially when combining local hormones with procedures like laser or injections?
Pacing and careful sequencing are vital, especially with sensitive tissue. The number one rule, introduce only one new thing at a time.
Why is that so important?
Because if you start a new moisturizer, a new lubricant, an LVO all in the same week, and then you get irritation, you have no idea which product caused it.
Right. So give each new product a trial period.
Yes. Allow at least 3 to 7 days with a new non-hormonal product before adding another. For hormonal treatments, give them a few weeks to start working before judging. This helps you pinpoint any sensitivities or irritant reactions accurately.
And what if someone is going to have, say, laser treatment and also wants to use LVO? How should that be sequenced?
In that situation, staggering is usually recommended. The standard advice is often to start the local hormone therapy, LVO or DHEA, first, and give it a head start, maybe 2 to 6 weeks before having the laser or injectable procedure.
Why start the hormones first?
Because the LVO or DHEA begins to improve the baseline tissue health and resilience. Having slightly thicker, better vascularized tissue can potentially make the procedure itself more comfortable, reduce the risk of side effects like excessive inflammation or spotting, and possibly enhance the results of the procedure. You're prepping the tissue first.
That makes sense. And after one of these procedures, laser, RF, injections, What's the immediate aftercare advice?
Respect the tissue. It's just had a controlled injury. So usually it's advised to avoid high-friction activities, including sexual intercourse, swimming, or very vigorous exercise, until any initial spotting, tenderness, or discharge settles. This is typically 3 to 7 days, but follow the specific advice given by the practitioner.
And washing?
Gentle cleansing with lukewarm water only. Avoid soaps. And when resuming intimacy, use plenty of a compatible, non-irritating lubricant and be prepared to reapply generously if there's any hint of discomfort. Listen to your body and don't push through pain while the tissue is healing. #tag outro.
This has been incredibly thorough, thank you. It really maps out that logical, stepwise path to synthesize. You start with those non-hormonal foundations, gentle hygiene, ditching irritants, getting the right scheduled moisturizer for baseline comfort, and a good compatible lubricant for friction.
The essential first steps for everyone.
Then, if symptoms persist and impact quality of life, the next step is guideline-backed local biological therapy, local vaginal estrogen or DHEA, to address the underlying tissue changes.
Working with the biology to rebuild resilience.
And only after those are optimized, or if they're not an option, do you selectively consider the adjuncts like energy devices or injectables, understanding their current evidence limitations, and that they aren't permanent fixes.
Exactly. And remembering the holistic side, pelvic physio for muscle issues, psychosexual support for fear and anxiety.
The crucial takeaway really seems to be that GSM is a long-term condition. It needs a sustainable, personalized maintenance plan, not just a quick fix.
Absolutely. And linked to that idea of managing things long-term is understanding product sensitivity. Can we just revisit that irritant versus allergy point? It trips so many people up.
Yes, please do. How do you tell the difference?
An irritant reaction usually happens quickly, stinging, burning, redness right after applying a product. It happens because the product itself is harsh or has the wrong osmolality for the fragile tissue. If you stop the product and simplify your routine, the irritation usually settles down fairly quickly.
So it's the product chemistry causing direct irritation. What about allergy?
A true allergic reaction is different. It's an immune system response. It's typically delayed appearing hours or even a day or two after exposure. It often presents as intense itching, maybe a raised red rash like hives or eczema, or significant swelling. And crucially, it will happen every time you're exposed to that specific ingredient, even a tiny amount.
So immediate burn is likely irritation, try a different formula. Delayed itch rash is more likely allergy, avoid that ingredient completely.
That's a good rule of thumb. Understanding that difference saves a lot of unnecessary worry and helps you find products you can actually tolerate long term.
Invaluable clarification. Okay, that leads us to our final provocative thought for our listeners, something to mull over.
Yes, tying back to diagnosis and mimics. If you are someone who feels like you're constantly battling recurrent thrush, maybe you keep using over-the-counter antifungal treatments, but the soreness, the irritation, the discomfort never fully goes away. Ask yourself this question. Could the underlying problem actually be undiagnosed or undertreated GSM? Remember that thin, fragile, high pH tissue is chronically vulnerable. Antifungals kill yeast? Yes. But they do absolutely nothing to thicken the tissue, restore the glycogen, lower the pH, or bring back the protective lactobacilli.
So if the antifungals aren't providing lasting relief,
it's a very strong signal that you might be treating the wrong target. The root cause could well be the GSM itself, needing specific tissue-focused treatment, non-hormonal or hormonal, to restore the health and resilience of the whole environment. Don't keep treating presumed infections if the real issue is the tissue itself.
A really powerful point to end on. Stop chasing infections and look at the underlying tissue health. Thank you so much for guiding us through this incredibly important, often hidden, but very treatable condition.
It was my pleasure. Knowledge is power here.
Join us next time for another deep dive into the research that shapes our health.